In healthcare, there is often too much information and not enough time. Here at the Melanin Initiative, we avoid TMI by breaking things down into language you can understand. We create a safe space for you to ask your questions and share a nursing perspective without taking up too much of your time. You may recognize our guest here. He's the guest of our series, Becoming Doctor of Nursing Practice, Demetrius Kirk, by way of Honolulu. He was kind enough. We actually just finished wrapping one of his episodes where he catches us up every semester about his journey in the DNP program. And he's been on multiple times talking about his inspiration to get into nursing, what that was like, where he started, the challenges, his perspective, his mental health, his relationship with his family and his wife, and the financial impact school has had. And we just wrapped that show. Originally, I was going to throw in some extra questions about a recent report that was put out by the American Association of Colleges in 22 on the state of Doctor of Nursing Practice education. Because me and Demetrius are long-winded, we went a little bit longer than expected, as every episode. And so he was kind enough to stay on another 20 minutes with me just to go through that report and get his perspective on some of the problems as well as the solutions that are presented there. And so we're going to jump right into it. If you don't know anything about him, go back and check out his playlist. We'll put that link below as well as how to connect with him. So let me just do our quick little intro. If you're new here, welcome to the Melanin Initiative. I'm Dr. Kimberly Madison, the Doctoral Prepared Nurse Practitioner, and one of your co-hosts here, along with Alicia and Geraldine. We're a health literacy podcast. When we say health literacy, we're talking about your ability to obtain information, to understand that information, and then to use it to manage your health and advocate for others. It's our hope that by watching on YouTube, LinkedIn, Facebook, or Instagram, or any of your favorite podcast apps, that you'll be empowered to ask questions, educated on how you can manage your health, and confident to navigate the healthcare system. That's our primary goal, to help you. The second one is to elevate the voice of nurses, to showcase our expertise, and to introduce you to all the opportunities in the healthcare industry. There's more than doctors and nurses running this show, and we want you to know who's on your team, who's available, and options for you if you're thinking about joining the profession. If you haven't already, this is your chance to subscribe, give us a thumbs up, leave a comment or two. It helps the algorithm see that this information is important, so that when people like you look for information like this, we show up higher in their search results. This show is for educational purposes only. The opinions expressed here are opinions alone. They're not a representation of any of our affiliations. If you think you might be having a medical emergency, you should call 911. If you think you might be having a mental health emergency, you can call 988 or text 741-741. Demetrius, welcome back, and thank you again for doing this.
Listen, I'm excited. I love, as you mentioned, right, we can be long-winded, so thank you for making a second series so people can focus on this topic.
So like I said, this report, the link will be below. It was written by the American Association of Colleges, or AACN, a really huge body in terms of credentialing and education and setting standards. And so in 2022, they released a report called The State of Doctor of Nursing Practice Education. We've alluded multiple times, kind of one of the reasons we've been doing Demetrius' series is because there's a lot of questions, there's a lot of confusion. And so by sharing his journey, we're hoping to answer some of those questions, clear up some of those confusion. And in this report, they actually mentioned that. They addressed it in a really big way. So it took me by surprise. They mentioned things in terms of solutions like social media, business, in terms of giving nurses more education and training in those areas. So really kudos to everyone on that task force who put this report together. And it's just really exciting to see that in real life, we recognize these things are important, and to see our credentialing bodies, who are people just like us, bringing that to our attention. And nursing specifically, I feel like we're kind of pioneers when it comes to leading the way, not being afraid to talk about things like diversity and inclusion. And that's throughout this report. It's throughout the current future of nursing from 2022 to 2030. It's completely filled with addressing these concerns. So let's start with the first one that they address, which is the variability in the different DNP programs and degree requirements. So diversity in DNP, Demetrius, welcome back. Because we just finished talking, I forgot that we just, this is a new show for some people. So welcome back.
Hi. It's all right. I know what we're trying to do. So let me give a quick introduction. My name is Demetrius Kirk. I'm a registered nurse as well as a licensed nurse home administrator. I have a master's degree in nursing informatics. I have a master's degree in business administration. And I am from Detroit. What up, though? And I currently live in Honolulu, Hawaii. So thank you for having me back to talk about the state of nursing practice. This report that came out in 2022. As you were actually talking, I was doing a little bit of my research and it was very interesting in looking at some of the facts. So let's dive into it because I'm sure you have some thoughts. I have some thoughts, and let's just see where we land.
I know by the time we wrap, we'll be ready to wrap. And so I want to make sure we continue to let people know how they can, what else you do. So you're an entrepreneur in this space as well. So go ahead and let them know how they can connect with you
Yeah.
in social media and all that, all the
Well,
services you offer. Your
listen. Let me plug. Let me listen. So, I am an entrepreneur. I own SMK Medical, which is a healthcare consulting firm specializing in risk and compliance. Our focus is post-acute care, so all things skilled nursing, AL, group home, home health, all of that stuff, post-acute care. That is my specialty. I also a podcast just like you called Sound Leadership with DJ, where we focus on all things leadership. I talk to leaders around the world at various stages of the career about all things leadership. And then I have a website called kirkleadership.com where you can go and find courses on leadership. You can hire me to be a keynote speaker, and you can hire me to be your executive coach to help you move the needle forward. So if you want to improve your KPIs, both personally and professional, Demetrius Kirk is your guy.
and you teach, right?
I do teach at the collegiate level, both academically, both on the operation side of things and the clinical side of things. So, from a clinical perspective, I purposely strategically teach fundamentals because that's where every nurse starts. And you need a great educator. And oftentimes, fundamentals is in nursing homes. And what better person than me, who is a licensed nurse home administrator, to take you into the nursing homes? And then on the operational side, I also teach new nursing home administrators how to be a nursing home administrator or people who are getting their master's degree in healthcare administration. I teach them the intro to finance course.
Okay. And you recently got John the name Paparazzi Poppy. Where did that come from, and who deserves the credit?
Paparazzi Poppy was a name given to me at the DNPs of Color event because as a podcast host, I took that job very seriously and I attended that event and I was doing on the spot interviews with other guests, other people at the conference. So I would see you walking down the hall. You might have just came out the bathroom, still got the napkin. I'm like, what do you think about the conference? What do you like about it? Give me your name. Like I was catching people off guard, but I was getting real moments, right? As the keynote speaker was delivering that message, and I see somebody eyes tearing up. I'm pulling out the camera, like, talk to us about how that's impacting you. And people like, it took them off guard, but we got real raw emotion and recorded roughly about 45 interviews. And out of that, I think the name what Paparazzi Pop came out just because I was everywhere that you wanted me to be.
Wonderful. Thank you so much. We'll put all the links below so that people can connect with you. And so that just was an example of how much perspective you're bringing to the conversation too, right?
Yes. Yes.
And thank you for your years of dedication to healthcare.
Listen, it's been long. I started at 18, 35 in 21 days. Oh, it's my birthday month, please. So know that it's my birthday month. 35 in 21 more days. So I'm ready.
And I love that actually I'm having this conversation with you too, coming off the heels of a virtual event last week with Brother to Brother, an organization founded by and built for Black men in nursing specifically to offer a safe space, mentorship, community examples for role model and leadership. And so they mentioned things that, man, we always talk about this is a male dominated society, right? We always talk about that, everything through the lens of that. And nursing's been female dominated, right? And so some of the things we do, we don't even, I don't even think about it until someone was like, yeah, the way we deliver nursing right now is from a female perspective. And you can easily say, oh, we do it that way because it works. Well, we do it that way because women like it, or we do it that way because it fits women, and until I heard that, it's just like all the other conversations, right? You have to come into the room where you're not the majority to see how they.
Listen, you just spew facts. One of the things I always taught, and I think the the numbers up. I think it's what 13% at last count were males. So it's definitely up from when I first got even into it. And then, as I start to look at the males in healthcare and start adding the labels on it, it gets lesser and lesser, right? Our males that are African American, now we're starting to dwindle, less than 5%. Then you say males with advanced degrees, starting at a master, I think it's less than 2. And then you add PhD DNP, it's less than 1% for Black males with that. So we're definitely, at least from my perspective, a minority, but we are changing that. And that's why I'm getting the DNP degree, because I want people after me to see that anybody can do it. It's just time. Time's going to move whether you move with it or not. So let's move with it and get the degrees, and let's elevate healthcare, but also elevate us.
Yeah, and so that's a great segue. So in the report, it actually notes that very fact that the number of women in, I guess it was getting the DNP, has decreased. And so that's certainly, the numbers can certainly be bigger, but the trend is moving in that direction. It didn't note gender identity, so we're just going to be going on whatever people checked on the box when they did the survey. So that would probably be someone who is looking at this lens through that would probably say, okay, that next report needs to break it down further. We do like to bring attention to the people who don't sit at our table as 3 straight Black women. We like to bring attention to the fact that give space for the people who aren't sitting here and make sure that we're considering them too.
You know what? One of the things you just said, and I'm sure it's caught out in the report, right, is sitting at the table. You made your own table.
Yeah. I think that's also entrepreneurial spirit, right?
You made your own table, right? You didn't wait for somebody to invite you to the table, and you made your own table. You saw a need, you're feeling a need with what you're doing. And like you said, yes, it's the entrepreneurial spirit, but you're making your own table, and you're making your own table with DNP after your name. So once again, you're showing others things that you can do outside of the clinical space. I think, and when I talk to people, I have people all the time, oh, I can't be a nurse because of blood or things like this. I was like, baby, there's so much to nursing besides just bedside. Like, we need our bedside nurses. I was a bedside nurse. We need that, but there's so much more that we impact and so much more that we reach as a nurse.
Okay, so the first topic that they talk about is variability in the DNP programs and degree requirements. And so there is, and these are some of the reasons why there may be some confusion or questioning the validity of the degree. So there's variations when it comes to focus on how much time is spent on clinical practice, leadership, and systems management. And this is why the perception of the degree is all over the place. So the solution that the report mentions is standardizing some aspects of the DNP curriculum. What are your thoughts on setting universal standards for the program? And do you think this would improve the perception and understanding of the degree?
I definitely do. And, you and I have had this conversation time and time again about the many entry points into nursing. But when it comes to the DNP degree, I think, yes, when you look at maybe the PA degree or a MD degree, right, there are set standards. And I think what was interesting when I met with the student group at the DNPs of Color Conference, everybody had a different set of standards that they were holding to. Now, we all knew about the DNP essentials. That's beating to your head, baby. So there is a set of standards. So I don't want people to think like we don't have a set of standards we're upheld to. But what was interesting is the amount of clinical hours we do, how we achieve those clinical hours, how we document those clinical hours. I think that was very important to call out, because for me, my clinical hours, I'm able to count a lot of things. But for some, they're like, oh, my school would never accept that. And it's like, okay, one of these are right and one of these are wrong. Which one is correct and which one's not, right? Should they be allowed to count XYZ, or should I not be allowed to count XYZ? I have to be mindful because I'm still in school, so I have to be mindful of how I word things, okay?
We'll revisit this in a year.
Yeah, but I think to your point, right, there should be some level of standardizations past the essentials. And when you talk about it giving it validity, I think that it will give it that level of validity. I know that my particular program, reason I chose my program initially is because you were able to get it done faster than 2 years, 21 months when I signed up for it. And then I guess the ANCC or whoever they're accredited by, CHIA, came back and said, hey, no, all DNP programs have to at least be 2 years. So that's a standard right there across the board. But I'm sure there can be some other standards as well.
I agree. And they mentioned that what you said, because there's so many entry points into nursing, people are coming in with so many different levels of experience. It is hard on a curriculum standpoint to have where do you start, right?
Mhm.
But it doesn't mean it can be done. It certainly can be done. And then some people have mentioned, so a lot of people agree that these standards need to be made and changes need to be introduced. But then they're also thinking of those are already in workforce. What would that mean for them in terms of the time, the money, the stress, and would it be worth it? So they're protecting, I feel like those generations.
Yeah, yeah,
Um,
definitely.
and so some people are talking about, well, just grandfather them in and just have, all the newer clinicians who are coming in follow these new standards. What do you think about that?
So when you say grandfather, you're saying what about people who currently have a DNP degree?
No,
Or
like instead of making everyone go back to school and get degrees, because you're saying now this is the standard of which we need
Mhm.
you to practice in terms of your level of education. Instead of doing that, just allow them to work with the degree that they have, because we know they're going to retire in 5 years or 10 years.
Yeah.
But all the people who are getting hired now, then have them meet this new standard.
And that's been done, right? So when you look at pharmacists, there's pharmacists with bachelor's degrees, right? And then there's now, the PharmDs. So that has been done. You look at OTs. There was a time OTs could be bachelor's degrees, PTs could be bachelor's degrees, and then they went to a strictly um, uh, PT, right? Or I forget how their acronym is, but they went to that doctoral level. So that has been done. And I think that if we decided to go that way, um, it could benefit us as a society. I think something that you called out is, the problem is people don't know what the DNP degree is. What is it? What do you do with it? I talk to so many people, and I'm sure the report calls out employers don't know how to effectively use somebody with a DNP degree, and that lends back to my statement, which I've always said, even before I had a DNP, there's too many entry points.
Yeah, you have said that. We have you on the record. I think the first time you said it, you were like, "I bet you weren't expecting that," and I wasn't. I wasn't expecting that. But yeah, I think, yeah, I certainly so I think with nursing, it just tries to be reduce as many barriers into
Yeah,
practice as possible. And I was thinking about this morning because, first of all, we're problem solvers, right? What's the problem?
yeah.
The problem is there's more patients than there are clinicians. So
Hmm.
someone says, okay, well, how do we relieve that? How do we get more people, more bodies to take care of this increased patient demand? Oh, well, we'll make it all these entry points, right? So now we've solved that problem.
Hmm.
But as you know, balancing measures, right? You solve one thing, but it
Hmm.
creates another area that needs to be addressed. And so I think that's where we find ourselves.
Yeah, it's like you said, it's checks and balances. It's kind of a seesaw, right? And I agree. We do need nurses at the bedside. We need nurses everywhere. So we got to do what we can to get our nurses out there. But I don't know that the area, when you look at a 2 year or BSCN or MSCN, I don't know that that's it. We talked about on my last episode, right? Barriers. Let's really get to the root. A lot of these people have these prereqs that they are taking that's so costly that they can't get through, right? And they need that whether they get a 2 year or 4 year. Do I really need to take an intro to religion class for me to start getting into nursing? Like, so I look at it from that perspective. Some of the financial barriers that people are facing for them to get into the nursing program and or pay for the nursing program. How do we relieve some of those barriers as well? I think if we had a standardized system, whether it's at the bachelor level or something, and we help relieve some of those barriers, or really made it where people can balance working. I've seen programs where people, the dean is excited to say, oh, my students can't work and go to school. That's not an excitement thing. That's not realistic in this day and age. That's not. So how do we balance that by also pushing our brand as nurses a little bit higher so that way we can demand more rate of pay or higher rate of pay? We can demand additional things. I've always said, and I'll say it again, right? The issue is when you have various levels of entry, there's always someone who's going to do it for cheaper because they didn't put in that time and work as a DNP student who holds this, or DNP nurse who holds the same registered nurse license.
Yes, we could do a whole episode on that one point. So you mentioned working in hours. So they talked about that there's been a recent push for all DNP programs to include 750 clinical hours to ensure that there's that consistent preparedness and the standards, right? A certain level of standards, like we see in our other programs. Yet some programs have struggled to meet these requirements. So one solution that they mention is possibly having a post-DNP residency program as a way to address the varied clinical experience. Do you think this would help better prepare graduates, or do you feel existing programs suffice where they are?
I had to do 1,000. I'm doing 1,000. I thought that was a standard, so it's they got me. Um, so the question is, would a post residency help? And I think that we're problem solvers, so we look at the root of the problem. The issue is, right, a lot of times students don't have access to preceptors. So how do
Right.
we gain access to preceptor? Because that post residency DNP, you're still going to have the preceptor issue.
Yeah.
If I can't get it while I'm in school and I have all the resources, how am I going to get it after school when I have less resources as a post residency? Just my thought. If our issue is preceptors, how do we tackle the issue at hand?
So you mentioned the other programs, right? Because med students don't work. PA students, I don't think they work.
But they get paid. The med students will get, once they get through, right, and they start doing their residency, it's like 60,000, but that's something in their pocket comparatively. So how do we just make it easier for these people in this day and age, in this society, whether it's more scholarships available to them or something? How do we make it? Once again, it should not be an exciting thing for a dean to come out and say, my students can't work. Well, that's why you're failing. One of the reasons I theorize you're failing to meet the admission gap. I talk to students every day and they say, I can't not work, have a family at home. That's a barrier. How are we addressing that?
Hi, I'm Alicia from the Melanin Initiative podcast. Our mission is twofold. One, to simplify complex health information so you feel empowered to ask questions, educated on how to manage your health, and confident to navigate the healthcare system. And two, to elevate the expertise of nurses, spotlight the diverse career opportunities within the healthcare industry, and inform our peers how to leverage their expertise as clinicians and entrepreneurs. In less than 2 years, we've grown to over 50,000 views and 1,000 downloads, with an international audience spanning the US, Canada, the UK, Australia, and more. Our engaged listeners are professionals, entrepreneurs aged 25 to 44 who value authentic, impactful content. Want to connect with this dynamic audience? Advertise with us. Send in your 1-minute video ad and let's amplify your brand. Email tmi.melanin@gmail.com for rates and details. Let's work together.
Okay, that's another point, right? First problem, more patients than clinicians. Second problem, not enough faculty. Okay, so let's go to the next one. This is that public and employer confusion that you mentioned earlier.
Yeah.
So there's evidence that some employers and even patients don't fully understand the role of the DNP prepared nurse compared to other advanced degrees that we've mentioned in this conversation. Have you encountered any of this confusion in your journey?
Yeah, because I was confused until very recently. I didn't understand until very recently, and I was a student, right? But I think that as I get more educated, I'm able to educate others. And when you say our role, I think it's very interesting. Segue a little bit. It was a topic at the DNPs of Color conference of, can we use the term doctor? Is that a title? Is that a job? What is it? So I was sitting with a CNO, and he, all throughout his interview process, they called him doctor. They printed doctor on his cards, but when he got to work, first day on the job, they told him, "Oh, you can't use the term doctor here." Why is there confusion on if he's a medical doctor or not? Well, the patients will be confused. Well, no, they won't. I can clear it up within 30 seconds. I know that's a whole nother thing, but it's when you ask that question, that's what I see when I tell people I'm going to be a DNP. They say, "Are you going to be a doctor?" And I have to provide that clarity. I'm going to have a doctoral degree, but I'm not a medical doctor. That is something different. They're a medical doctor.
So one of the solutions that they proposed is to strengthen the relationships between academia and healthcare organizations in terms of like bringing awareness and education, kind of like what we do on this platform. What do you think could be done to help clarify the distinct roles of DNP graduates specifically for healthcare employers?
I think it's educating them on the knowledge base that DNP students or DNP prepared nurses have. To your point, right? They don't know once we come out, they see a nurse. That's what they see. They see a nurse. But so, what makes you different from a master's prepared nurse? What makes you different from a doctoral prepared nurse? So, how can we as universities, or how does universities provide this education to healthcare systems? And they have to let them know that, hey, these DNP prepared nurses are ready to implement new evidence based practice. These DNP prepared nurses are trained to think on a systems level. So it always hurts my heart when I see DNP nurses working at the bedside and things. Yeah, there's a place for it, but I think about the knowledge they gain. I'm like, you could really be improving the overall health system. You can really be implementing some new practice, providing education. There's so many issues at the hospital level, at the national level, at any level. How do we get those DNP prepared nurses in those roles to better the outcomes of patients?
So you mentioned two things. One, so in the report, this people who have, the survey was that employers do recognize that DNP trained nurses do come with more understanding in terms of leadership, systems level thinking, and finances, right? And it just so funny. The other day, I was taking care of a patient, talking to my team, and I mentioned why I prefer one over another. And I said, well, because one, it's not clinically indicated any longer, plus it's more expensive. And he was like, I never heard anyone care about the cost. And I said, well, y'all care about the cost because y'all call me and tell me I picked a treatment that was expensive. So it's made me more aware of the cost.
Yeah.
But he was really taken aback. And it's really, really challenging to try to get the nurse to really, even though they hear me saying it, it's really hard to drive that through. And I remember being a nurse at the bedside. We didn't have the same I wasn't having that conversation with people, but I would just grab whatever was available, right? I'm not looking at the cost. Although we did at one point put the price that we did know for different, say, dressings in particular, and that did have a really big influence on which ones we picked. But even then, patients would come in, maybe they get into an overflow room that's barely bare bones, and they would say, "How much am I paying for this?" And it never crossed my mind that they should pay less than someone who had an actual room, right? Because it's not part of the language, and it really has to start so much sooner than it's being at the doctorate level.
I've said it from the beginning. These programs, in unpopular opinion, these programs are not preparing nurses or healthcare providers or nurses rather for those kind of conversations, right? I think there's definitely should be some level of intro to finance course, some level of leadership, right? Because when a patient looks at you
Yeah.
and they are saying exactly what you're saying, you should be able to converse with them and not say, "I don't know, not my
Yeah.
job."
Oh,
That's not acceptable.
it's not.
It's not acceptable. I don't know, right? So as a home care nurse, right? I'm in these patients' homes. I have to help them prioritize if they're gonna buy food or their insulin.
Yeah. Yeah.
I'm here. That's a real systematic problem. I don't have a social worker to come in. So how, as a nurse, can I help them? I'm not saying you need to be a master of finances or things, but you have to be able to navigate those because those impact our outcomes. Social determinants of health.
Okay, so two things for entrepreneur, help me remember that. The first one I just wanted to touch base on. So even though employers say they're confused, and even though they say they recognize the value that DNP trained nurses bring, they're not doing any data to distinguish the differences. And so that was an area that can be addressed. Listening to you talk, right? I thought immediately, entrepreneur. I thought about an idea because you know how we have GoodRx for like pharmacy and we look up drug comparisons. That bedside nurse, that home health nurse, whatever, should be able to go to some app, hello informatics, and look up that kind of thing. And it should be on everything from dialysis to home care equipment to insulin. I'm telling you, is someone out there?
Listen,
Is this?
I'm with you.
Yeah. What do you think about that?
Listen, I'm with you because it's real. This is not acceptable. I don't know. It's not acceptable.
And
So
that reduces our ability to further advocate for our patient, right? We can advocate on all these other points, but when it comes to the cost, I'm silent. And that is neglect. That's
we shouldn't be, right? I'm in the clinic setting, right? Or I'm in a long-term care setting or any setting, and I'm making recommendations to the doctor. And oftentimes, right, the doctor, they're busy, they're taking my recommendations, but I'm making recommendations, and maybe it's the most expensive recommendation I can make, and because I don't know any better or I don't know alternatives. One of the dressings I used to order all the time, didn't know the cost. I think it's called like Tefla Blue or something like that. Something blue.
Oh, Hydropheric Blue?
Oh my God, that's expensive.
I love it. So oh my gosh, I literally was talking about this.
So expensive.
I was telling the nurse, I was telling somebody that it was too expensive to order every day.
Yes.
We don't order this every day. And they were just like, well, we only use a small amount. Like that's where that's the problem. That's the problem.
I wrote an order for that, not knowing. And I got a nice call from the administrator very quickly that we will not be changing a dressing twice a day with that medication. With that. And I was using the whole pad. And that's what we don't know either. We put the whole pad. I wasn't cutting the size.
Yes. Beautiful. Shout out to
waste.
That's a beautiful dressing. Congratulations to Dr. Yvette Conyers. She just announced that she joined the board of all these abbreviations. Wound Ostomy Continence.
Wow.
Anyway, she just joined the board, and so we're going to have her back in the new year so we can learn all things wounds, ostomy, continence care. That's what this whole dressings, lots of money there. $1 billion part of healthcare alone. So we're talking about money, right? So let's talk about pay. So given the advanced competencies of DNP graduates, there are ongoing discussions around pay disparities. Do you feel DNP graduates are recognized? Do you feel like we're recognized for our financial skill sets?
For our financial skill sets, or are we paid appropriately based on the DNP?
Yeah, are we being compensated? Is there a difference between me and my colleague here who didn't go to get their doctorate?
No, and that's unfortunately, and you notice that at the bachelor's level, right? You might get 25 cents once you go get a bachelor's, but now the hospital's magnet status, but you've given me 25 cents. So, one of the struggles is there's never been a pay increase as you climb up the rank. And that's why a lot of nurses, they don't.
Up the rank. They mentioned that. Did you already have a summary?
No, this is me. This is how I feel.
They said that. They said that exact thing, right? You can work more doing what you're doing.
Why? Why would I ever go up and get a bachelor's degree if I'm not going to make anything more? I'm going to have debt that the school or the job is not going to help me pay off. If I go to a master's degree level, if I don't want to teach, then what is the benefit? And there's other benefits there, but let's be honest. People are motivated by financial gain. That's why any of us, we love what we do, but there's some financial attachment associated with it.
Yeah,
so,
that's true.
When you look at it from that perspective, from a DNP perspective, no, I'm not getting a DNP because I think it's going to elevate me financially. And that's not why I'm getting it. I'm getting it to show every black and brown boy that you can do exactly what I've done. That's payment enough. Nobody paying me for this DNP degree.
So they said that. That's what people said in their report. So
they got this report from me.
So one of the solutions was that there needs to be more data, as I mentioned, on DNP outcomes to demonstrate our impact. Do you think gathering this kind of data, making a case for appropriate pay and recognition would really make a difference?
No. It's great to have, but companies are companies. And so I put myself in an entrepreneur mindset or as a CEO mindset. Yeah. I don't need you to have a doctorate in theory to do the job. And that's how they view it. And once again, I don't need that. So no, I don't think there's a difference. And I look at it from a CEO perspective, right? And I go back to, I always level things back to my barriers to entry. Unfortunately, I can get a BSN nurse to do your same exact job, even with a DNP. On face value, I'm saving money, but I may not understand the intangible benefits that a DNP will bring that's going to improve outcomes because they understand systems thinking. If I'm only thinking about finance, then I'll just hire a BSN. And unfortunately, our leaders, the people who are running these companies, are only thinking about finance, which is a tangible benefit versus an intangible benefit.
Yeah, and I think there's an argument to be made on the clinician side that even faculty, maybe administrator, you would have to speak to that even the pay we're getting, even if we do just have a bachelor's, is still not enough because of the demand by the system, whether it's patients, student demand. We talked about the faculty shortage. The demand is increased, but just like pay, it doesn't increase, though the cost of living has quadrupled. So
100%
there,
facts.
maybe there's where we should be leveraging our striking power.
Well, I think 100% facts. And you talk about, pay for educators, and it's not just nursing. I share my wife as an educator. She doesn't make a lot of money as an educator. It's how do we get our educators more money? Because then they're more apt to go into education. But it's hard for me to leave a 9 to 5 where I'm maybe working from home to go into a classroom setting and stand up and have to teach and take a pay cut. It's a challenge for people to do that. And, shout out to the teachers who want to teach, but I think it's a deterring factor when you can see the difference in pay from being an educator to, working in a different setting.
And I think there's a lot to be said about both teaching and nursing being predominantly female, and
Yes.
women only just getting the right to have our own bank account and our own home less than 50 years. Maybe wait, is it 50 years? Not that long ago. Okay.
Yeah.
Within my parents' lifetime.
And to your point, I think that also plays a factor, when you look at the who's dominating this field, right? It is mostly females. And, history will say, and choose my words wisely, but, oftentimes females are not apt to stand up and ask for more money.
No.
And when you're not up to ask for more money, then you take what they have, and that becomes the new standard because Miss Smith is accepting 20, so you should just accept 20. Even if you want to stand up, well, now there's 10 Miss Smiths, so now you look like an outlier. Even though you're correct, you look like an outlier asking for more money when 10 Miss Smiths are working for $20 an hour. And that's a problem that we have is people are accepting it versus standing up and saying, no, we should be compensated at this level. We need to bring our floor up to adjust for, inflation and everything else. There's still nurses, right? And I used to not like hearing this when I was just getting in the nursing field, but I remember nurses said, oh, you're making $22 an hour. I made that 10, 20 years ago. I'm now the same nurse saying that 15 years later into nursing. I'm watching new LPNs come out of school, new RNs come out of school, and you making anything, you make $25, $26 an hour. How is that still acceptable? They were making that when I came out back in 2012. And when I hear now, the senior nurses say that same exact thing, I understand it as I've gained additional education and life experiences. It is not okay. Nurses are not paid enough. Educators are not paid enough.
And there's something to be said about, on the business side of it, if nurses take up such a large percentage of the industry and now you want to have their pay go up, that's going to hit my bottom line big time, right? You have to, if I'm going to give you more, I have to take from somewhere. Where am I going to take it from? The patient?
But it's always interesting, right? When we talk, so we can get in finances, we can have that conversation. When we say, where does it come from? Every business is different, but you still have business hitting record profits. Where does it come from? Maybe you don't need to make 10 billion. Maybe this year you make 9 billion. You don't have to increase that's a profit that's going in somebody's pocket. But unfortunately, as an administrator, my job is to drive KPIs and drive revenue. So I don't look at it from that perspective. From a clinical perspective, I can see it clear as day. When I look at down at the bottom of the line, and this month we profited $1 million and we're on track to profit, $5 million next month. We're doing that on somebody's back, just being honest.
Yeah, and there is something to say about, because we're talking about these female-dominated industries being also dominated in leadership by men, and that whole dynamics of men not wanting to pay women more than they make. Some people would say that will never happen.
You look at something, and we don't have to get into. I'm not a sports guy, but what I can, I get it, right. Revenue is everything, but you look at the WNBA. Compared to the NBA. Granted, there's always things that impacts it, but that's another example of, something that's kind of dominated by women and the pay disparities there. You bring it back over to healthcare. Once again, it's dominated by women and there are pay disparities here. But what I can say is, because I've heard it before, when I first get into it, you are male, you're going to make more because you're male. That's a lie. I ain't never made more than my female counterparts. I'm here to set the record straight. But I've heard people say, as a male, you make more. Not one time.
What? Yeah, I believe that.
Not one time. What may have happened is, and I tell people, I may have gone back in and say, or come back and say, this is what I'm willing to make, and either you take it or leave it. But I don't think there's a point where if that I was making substantially more. I'll go in there in the middle and say, you know what, XYZ down the hall is going to pay me this, so you need to match that, and then they will match X, Y, and Z. But I guess you can put it on the fact that I kind of asked for more, but it was just a question. Some jobs have said no, and this is what we pay, and I get right the same amount as my female counterparts.
Yeah, maybe that's a bit. I don't know too many. There's all these coaches out here. I don't know about the nurse negotiator coach. If they exist, leave us a message in the comments because
You're
that's
talking to one right now. Let me tell you how to get this coin.
Well, you just said you're not making more than your female counterparts. I want someone who's like, yeah, I came in and I got
No. I mean, but here's the deal. There's a floor for every job, right? So when we say making more, right, there's a range. Nobody's going to any company blowing it out the range, right? If the range is 25 to 30, they're not going to come in and say, you know what, we like you, so we're going to give you 40. That just is not going to pass their board of directors. I'll get top of scope of that 30. I'm not going to come in at the lowest, but what I mean is when I say I'm not making more, I'm not blowing anything out the range. I'll get top of scope where my female counterparts may get the lower end of it. But to me, if there was a scale, that's still the scale.
Oh, yeah. And this is a plug for entrepreneurship, right? You're never going to make more than the person who owns the company. So
100% facts.
There's a ceiling there. So if you're happy with being at the ceiling, then keep on. But if you want to go beyond that, then you got to start making those dreams come to reality. So in our previous episode, we talked about the PhD trained nurse, right? And so there, it's often contrasted. All of us, even yourself, you said, I looked at that one and I don't like research, so I didn't want to do it. And so the distinction there is sometimes blurred, maybe in people who are not in the industry. How do you view the DNP's role relative to other advanced nursing degrees in terms of academic versus practical application?
So I think we're more practical, but with that being said, I think you're definitely academic, meaning, a lot of times people say, well, you're DNP, you can't teach. Well, newsflash, I taught with a master's, so you're not going to tell me I'm getting an advanced degree and now not teach if I'm teaching with less, right? So from a practical standpoint, PhDs are more research-based and they often are in the classroom. That's what we're used to seeing. But as these DNPs up and come and they become more clinical based, they are now coming into the academic setting and starting to take on some of those roles that are not filled by PhD trained nurses. I'll say that I teach currently at a master's level. I teach like an intro to health sciences. And when I get my doctoral degree, they plan to keep me right there, right? Teaching med term and things like that. So, there are so many things that you can do with this advanced degree that is rather directly in nursing or adjacent to nursing. Once again, I'm teaching people who are taking intro to med term and things like that. So with this DNP, the degree allows you to do is one, have a terminal degree, but also be able to translate research into practice, but also teach at the academic level as well.
Okay, so you brought up a point that's brought up in the report, is that a lot of nurses, when they go back,
I promise I read this.
when they go back, well, now you're kind of giving it some life too, right? Is that when we go back and get our doctorate degree, we end up a lot of times staying in the same role. And you just mentioned they're going to keep you right there. So someone can make the argument, what was the point of going back if you're going to do the same thing and get the same pay? And then what's the difference between you and that PhD trained nurse?
Well, I think to the point I was pointing out is that I'm not in nursing, I'm adjacent. So as a DNP nurse, right, or DNP prepared nurse, I'm still at the collegiate level doing other academic education offerings as well. So that was the point I was trying to make with that statement. Once again, I can teach clinically, or stepping outside, I can teach other things in the healthcare sector. The difference between me and a PhD nurse at the clinical setting, I don't know that I have the, I mean, at an academic setting, I don't know that I have the answer to that, right? I don't know that there is a difference if we're both providing the same level of education to the students, following the same coursework and the same lesson plan. I don't know how there can be much difference if we're following the same lesson plan. Once again, when I look at my PhD counterparts, shout out to Dr. Sylvia, who's a big advocate for PhDs in nursing. she's often referring to research. She's always doing research and trying to do publications. And me, on the other hand, I guess if I'm talking to students, it would be more on the clinical side, trying to push students into that realm of, clinical and using new evidence-based technology and new tools and things like that. So, maybe our delivery will be different, but we have to deliver the same information.
So maybe we need to have a future episode with Dr. Kimberly Souffrant and some of her other PhD friends so they can provide clarity on this. But I would think the argument could be made that a PhD trained faculty could bring in or could make a case for higher pay, because technically, isn't it part of their requirement to get grants for the university? Well, that's just like the athlete, right? They have to bring in, and so those schools tend to have more money and better amenities.
I agree with you. I think, like you said, a lot of it is for the PhD trained nurse is to continue publications with the school's name on it and things like that. I don't know where the DNPs land in that because I'm not in that circle as of yet. I will be very soon. But I know for my PhD counterparts, right, they are always doing publications or doing things to promote the school. I imagine that they will still want that from a DNP nurse. You still have a terminal degree and you may partner up with PhDs and things. But I kind of go back to the pay disparity, right? Should there be more pay for a PhD educated instructor versus DNP? I don't have the answer to that yet because I'm not there yet.
I'm sure they're in the comments letting us know. But I do. I look forward. We're gonna have to do that. If we don't do that on this show, then maybe we can do it as one of our speaker series for DNPs of color. Because I know there's a lot of requests over there too to get more support and mentorship for new faculty like yourself. Yes. Right. And then at that, higher levels within academia, which I heard can be a beast. And so so we got, just like nursing, one question always leads to more questions. So let's talk about assessing advanced competencies. The report highlights that advanced competencies in leadership, that's your thing, systems thinking and policy as key aspects of the DNP preparation. Has your program emphasized these areas, and what challenges do you see in providing competency in such non-clinical skills?
So for the people who are listening in, I'm thinking, I'm trying to formulate an answer. I don't want you to think. So my particular program does emphasize systems thinking, and a lot on population health, which I was kind of shocked about as well, does emphasize systems thinking. When it comes to assessing competency, I don't know that can ever be assessed from a textbook or from a paper. Leadership is one of those things you just have to be doing. And when you talk about systems thinking in nursing, the problem with nursing, any program, right? You have every situation and it's perfect. But when you're in the real world, it doesn't go that way, right? There are factors to consider, stakeholders to consider, and things like that. So, we can only assess it as much as you can in a paper, but when the rubber meets the road is when you're out there in the real world and you're bringing what you've learned into that setting to try to move that organization forward. I think the problem with any of this is that the books, as always, this is just a fact of life. The books are only as good as when they were printed. They are always not current. So none of my books are talking about AI. Well, that impacts systems now like never before, how we do anything. But none of my work is going to ever reflect that just because it's already old and it's not in the curriculum. So, it's when we go back to how do we assess that? Can we assess that? I don't know that you can, because technology is ever changing and the world is ever changing. And if you're looking at old material, but you're looking to grade me on old material, how can you do that? Because it's just not realistic. We're not in reality.
When I heard you talking about that, it made me think about how physicians have their all those board exams and all those orals that they have to give, right? Yeah. And you think, okay, well, we could just create another exam, right? But because there are so many different DNP degrees and outcomes, it's really hard to make an exam for that. I'm sure it could be done. And I think in the report, it mentions for each track to have something where they're kind of addressing this essentials, right? Making sure they were met, but in a examination format. But it also made me think of our MBA friends, right? They don't take a certain final after to say like, okay, now I officially met all the requirements. You hear someone has an MBA and automatically they just get like elevated. You just
Is
know that,
that
they met.
is that what happens to them?
Everyone's like, yes, I have an MBA.
Hold on, let me do that. You see, I added MBA after my name. I'm
Yeah,
elevated.
everyone questions their level of credibility. You know what I'm saying?
Yeah.
Like there's just a presumed understanding that they met some kind of mark.
Once again, so I have an MBA, and what I will say is it does. When I first got it, felt like a secret club I got access into. When you tell people you have an MBA, I will agree with you there. It's kind of like, oh, you get it, you have an MBA, right? But MBAs are to the same thing as a DNP, right? There's so many variations in them, so many fly-by-night schools. Doesn't mean anything because you have an MBA. It's no way to assess your skill set. I think the only way that they assess it is my MBA had a capstone project. Same with a dissertation for us as DNPs and PhDs, right? We have that dissertation. That's really the only way that you can kind of assess. But even still, that's just paper writing. And for my MBA, it was a project. I had a business, and they didn't care if the business failed or succeeded. You just had to do a report on either why it succeeded or either why it failed. And if it failed, what could you have done to make it succeed, and vice versa. So, I understand exactly what you're saying. I don't know if providing some kind of test at the end of it will solidify anything. I'm not as fond of that. I think that education, experience is the best teacher. So after they get the education, students have to go out and be able to apply it and seek organizations that are willing to put them in positions to apply what they learned in the school setting, so that way they can attempt to improve the system as a whole.
And so that kind of speaks to one of the other points I had mentioned previously. And one of the possible solutions is that once you do get that DNP graduate in your job, maybe they have the same title as your master's prepared employee, but in addition to taking on that role, they take on additional responsibilities. And the report did mention that they do tend to see that more often amongst the DNP graduates, that they do tend to take on additional responsibilities, but that's a free will, right? So perhaps it's where it's not free will and it's like expected or standard or part of the job description.
But you go back to, right, the pay. So if I'm going to take on some additional,
well, yeah, so this would help because now you can get data, right? Our numerical qualitative data that we spoke to about earlier. Once you get enough of that data, you should be able to go back and see it made a difference that this person was here.
Yeah.
The numbers are the only thing that's gonna, the qualitative
show anything
matters too, right? But the numbers at the end of the day, what we want to see, that something you did or said made a difference in our numbers and our outcomes in the patient and our ROI, all those things.
I love the fact that you focus on that. And that's one thing that, whether I don't care if you're at the DNP level, at least my particular universities, even at the bachelor's level, didn't focus on. And I might have mentioned this earlier in this episode or my other episode, but no matter where you are in your nursing practice, you need a basic finance course. I think you need that at this DNP level because, right, you're supposed to system think. But how do you system think if you don't understand the numbers?
Because so much information, so much emphasis is on patient-centered care, which I love, right? It's great. I don't have a choice. But what I'm emphasizing lately is provider-centered practice, right? So a lot of that has to do with me holding back a little bit so I have something left in the tank for myself, for my family. And if everyone on the team does their role, even though they're holding back a little bit, the patient will still get the best care. They will still get patient-centered care, but I too will still have something left in the tank. Maybe that will lead to less burnout. Maybe that will lead to increased retention. Maybe that will help it so that we're not becoming the patients in the bed too, right? And so because so much emphasis is on patient-centered care, we forget about everything else. And that's why as clinicians, we get so up in arms when the powers that be make decisions that have nothing to do with patient care, because they're not in the patient care business. You are. They're in this whatever kind of business they're running. That's what they're in charge of. And that's why we always butt heads so much, is because we're not speaking the same language.
One of the reasons that I went back to get the MBA, right? I got my MSN first, and then I got my MBA, because I was sitting at the table, but I wasn't digesting what was on the menu, and I wanted to digest what was on the menu. So I've arrived. I'm sitting at the table, but just because you're there, if you can't read the menu, what are you really doing at the table? So I went back to get that MBA so I can read what's on the menu and I can order appropriately and tip where necessary, right? So when you look at, the knowledge that nurses need, I'm not saying you need a full-blown course once again, but you need to understand the basis of finances, especially at the doctoral level, because oftentimes you're prepped to be the CNO. And you're in these meetings as a CNO, and they're telling you why you can't get the bladder scanner or the vein finder 3000, or you can't do X, Y, and Z. We talked about the wound care supplies, why you can't. But if you had the numbers, you understood the numbers, you can say, but we're improving outcomes this way, so I can get that hydrofarine blue or whatever it's called. I can get that because we've decreased our length of stay by X days, which has put more revenue back into the pipeline, decreased our expenses, right? We're now cut our dressings down from 2 times a day to 1 a day because that dressing super absorbs. Now we can not use that and change twice a day and spend just the same amount of money. Exactly. But we as nurses don't know how to say it in that way.
But we understand it. And because I hear them saying it, and it's like they just don't know the length. They don't know how to frame it into that argument.
Agree.
Yep. But they're witnessing it, right? So we have 2 more questions, but I'm going to save them for when you come back because they're kind of extensive on their own. But I can't thank you enough for delving into this report with me. I know we're going to get a lot of comments on this one.
Listen, and thank you for having me on. I love to talk about all things leadership, all things nursing. I have a passion for nursing, so thank you for having me back on.
Yeah, and it was nice to go to have that kind of conversation with you outside of your student role, right? And to hear your expertise in all the areas that you are an expert in.
I don't know what you're talking about. I'm just here. But thank you. I appreciate you.
Yeah, and I think these conversations, they'll keep going. And in 50 years from now, we'll have moved the needle a lot further. And this will be just like a thought, right? But in order to get to that place, it takes what we're doing now.
Well, when you look at it, I'm sure for somebody, the DNP degree was just a thought, right? It was always PhD was the terminal degree to have. Yeah. And then somebody said, but what about these other nurses who can probably just translate and not really focus on the research? And now look at it 20 years later.
Couldn't have said it better myself. We'll put all the information so people can connect with you in the description box. Remember, you can email us your questions and show ideas at tmi.melanin@gmail.com. If you haven't already, this is your chance to subscribe. Leave a comment in the comment section. It lets the algorithm know this information is important so that when people like you look for information like this, we show up higher in the search results. At the time of this filming, we release new episodes weekly on Sundays at noon Eastern, live videos on YouTube, LinkedIn, Facebook, Instagram, and then the audio drops on your favorite podcast app at 5 a.m. So our night shift friends can be the first to get something and not the last. Day shift has something to listen to, and maybe someone will play it during huddle. We can't thank Demetrius enough for spending all this time with us today. Make sure you go back and catch his series, Becoming Doctor of Nursing Practice, so you can follow his journey. We thank you all for watching. We'll see you next time.